right, good afternoon, everyone. Welcome to the last of our 2018 Mondays in March presentations. We previously had the opportunity to hear from Ms. Sollenberger, Dr. Jacobs, and Ms. Sadro about the perspectives, their perspectives on where the various components of our organization stand, how we're doing in terms of accomplishing our goals, what we see that is working according to plan, what's not going according to plan, and our current thoughts about how we move things that are not on plan, including our finances, back to where we want them to be. So today what I'd like to do is just open with a quick synopsis of each of those presentations. Now these are mine, so I'll give the actual presenters an opportunity to correct or clarify related to whatever I have on these slides. What we'd like to do, though, is to use the majority of this time until the 1 o'clock hour to respond to any questions that you all have. And we hope that you'll be forthcoming with your questions, that you won't be shy, because we truly want to try to be very open and transparent and provide all of our current thoughts about anything you'd like to discuss. So let's just dive right in. These are the things that I took away from Ms. Sollenberger's presentation. Number one, we're an incredibly resilient organization. That certainly is our history. That's been the case for 125 plus years now, and we expect to be that to be the case as we move forward. Now we know that we're living in a time of challenge. She showed a slide about the top 10 concerns of CEOs of major healthcare organizations, academic and non-academic, from across the country, and they're pretty much line for line aligned with ours. It's a tough time right now, particularly for academic medical centers. We all know that research funding doesn't completely cover the cost of research. The same is true for public funds that come in support of educational efforts. So that means places like us have to generate clinical revenue to support that mission work in education and research. And what's happening right now with reimbursement for healthcare? At best, it's stable, right? And yet our cost, our expenses, are rising in some cases exponentially. So we're all worried about that. How do we make ourselves more efficient? How do we grow selectively so we can grow our revenues, so we can continue to support the important mission work that we do in education and research? So I think that's pretty much on everybody's minds all across the country in places like UTMB today. For us, best care is still the priority. We've made significant advancements. We're certainly making the case that we're one of the organizations in the country that consistently is delivering what we consider the highest quality care to our patients. And certainly that's part of our mission. That's what places like us are supposed to do, define what high quality care looks like right now and into the future. So we're doing well on that front, but we need to continue to plan to sustain our gains and hopefully improve on our current status over the course of time. Mentioned this earlier, the health system continues to grow. As we move forward and we look in the great crystal ball of healthcare, what we think we see is that organizations that control the larger number of patients, and we can argue about what it means to control, but basically have patients attributed to them, large numbers of patients who use their services, are the ones who are going to be best in the future in terms of determining what happens with those patients and with the healthcare system. So it makes sense for us as a large system to try to be larger. Now, does that mean entirely we should be focused on organic growth? No, we're looking at different forms of collaborations, partnerships, affiliations, so we have broader access to larger numbers of patients over the course of time. And as Ms. Sollenberger mentioned, I mentioned earlier, of course, growing revenues is important. We need to figure out how to do that in a very efficient way so we can sustain our educational and research missions. The growth plan that we have, because of the region in which we operate, involves a lot of investment on the mainland. Now, our strategy really hasn't changed. Galveston Island is the home for our tertiary quaternary academic hospital, the center of our health system. But we know that patients, our patients, want us to have community and community plus level services close to where they live and work. And of course, most of them live and work between Galveston and Houston. So we continue to develop our strategy, define our tactics, implement those tactics to expand our services, our sites of service, so they're more accessible to patients in our target geographic areas. Finally, transformation of healthcare is essential, and it starts with us. And this goes back to our role as an academic center. Everybody, maybe not everybody, but just about everybody in the country who's engaged in the delivery of healthcare is thinking about how we transform it for the better, how we make it more efficient, more effective, more equitable, safer, all of those things that we're supposed to do, all those characteristics that are supposed to define high-quality healthcare in this country. So we're very much engaged in that process of transformation. The bad news is, probably isn't going to go away. In fact, the need for transformation is probably going to intensify as we go forward. But go back to the first bullet, one of the first points of Ms. Sollenberger's presentation. We're an incredibly capable and resilient organization. If any organization is enabled, knows how to manage transformation, it's UTMB. So, Ms. Sollenberger, those were the takeaways, my takeaways from your presentation. Do you want to add anything, clarify?
No, I think you covered it. Only thing I would say, because it's embedded in the resilient organization, is that we have exceptional employees. You all are among that. And I know any time of change, which we've certainly have plenty of that, creates anxiety because we don't know exactly what's going to happen in the future. We try to do our best to predict that. But the success of the organization really is going to rely on the incredible resource of employees and physicians that we have at this organization. And our challenge as leaders is to make sure that you are engaged so we see and understand your ideas, because that sort of grassroots level of ideas is what will really help to make us successful.
Excellent. Thank you. All right, Dr. Jacobs spent some time talking about the marvelous accomplishments of the faculty and supporting staff in the academic enterprise, the entire organization obviously contributing to these successes. So great research accomplishments, tremendous number of accomplishments in all of the schools in our training and education programs. We continue to grow the recognition of our faculty and our programs in both research and in education, and that's what we're supposed to do. He went on to outline what our current plans are for continuing to grow research, growing, establishing, more firmly establishing an infrastructure that will support clinical trials, and that's aligned with our strategies in academic medical center and also the desire to grow engagement with our patients and the numbers of patients. We know patients, particularly those with chronic diseases, are attracted to places that offer novel therapies, usually delivered through clinical trials. Clearly, the need exists to expand our informatics capabilities, to better understand what's happening, to be able to more quickly analyze and interpret what's happening and convert that into changes which improve our outcomes and all of our programs across the university. Improving patient access and reducing migration of referrals. We want to be able to deliver very effective and efficient care. And there's more demand for our service today than we can actually satisfy. So we continue to look at our systems for improving access to UTMB, and also making sure that as we seek to manage patients as efficiently as we can, that we provide the opportunity for our primary care patients to see our specialist, for our specialty patients to get established with our primary care physicians. So a lot of work going on within the academic enterprise, within the faculty group practice, extending through the health system, focused on both of these issues. One of the things we continue to work to do is to bring in more scribes to help with clinical documentation. We know across the country, one of the biggest dissatisfiers for people providing clinical care is the documentation level or load that's required associated with most of our electronic health records. We know that we can be more efficient in terms of seeing patients if we can redistribute some of that documentation effort with the use of scribes. Now, one of the challenges we have, and Dr. Jacobs described this very well, there aren't a lot of scribes out there. So while there certainly is a recognized need to employ scribes, we haven't really been able to keep the pipeline filled with people who will serve in those positions. But we're working on that internally. We have plans to expand the number of scribes who are supporting our clinicians here, and we're certainly going to continue to implement those plans as we go forward. Finally, ensuring that compensation is appropriate and competitive for the faculty as well as the people who are supporting the faculty. Dr. Jacobs showed a series of slides that looked at our investments in compensation, where we stand today, and what our goals are over the next 3 to 4 years. So Dr. Jacobs, those were the takeaway messages that I perceived. You want to add anything to that or clarify?
I think that's a great summary as usual. I guess what I would hope was evident or will become increasingly evident was the context, and that was all these things we're talking about, the academic enterprise around future plans are really, if you don't mind this sort of description, trying to make sure that we do everything possible to have folks understand the joy that should be part of what we're doing, to understand the investments are about making sure you all are happy, because if you're all happy, you feel like you're contributing to something that's greater than oneself. That's important to me, but I think that's how organizations thrive and prosper. When the going gets tough, the tough get going, of course, but it's why, it's the why question. All these future plans are about bringing back the joy, or making sure the joy is maintained in academic medicine.
Thank you, sir. Ms. Sadro spent a lot of time talking about the budget process, talking through where we've been, how we put together our budgets, how we take different inputs, if you will, and bring them together, align them to create our budgets, and how we do our best to manage them during the course of any given fiscal year. This particular fiscal year has been particularly challenging for us. It started out rough with Harvey and its immediate impact. That impact seems to be continuing through today, where across the Houston region, patients are spending less on health care than they did before Harvey. And we're seeing that in the financial results of a lot of large healthcare systems, whether they're public systems or private systems in the greater Houston region. She also talked about some of the ways that we are vulnerable with some of the populations that we see, particularly given that we're a safety net hospital. As we move forward, and it becomes harder for unsponsored patients or Medicaid patients to access some of the other hospitals, the demand for UTMB to provide those services grows. And of course, that's part of our public responsibility, but how do we best meet that demand, and how do we do it with reimbursement rates that really don't completely cover the cost of providing care, at least by today's standards? So again, transformation is required. We need to continue to look at our systems, think about how we do this, and when we don't meet our budget, think about the reasons behind it, behind not meeting budget, work to change our processes and take corrective actions so that we can generate the revenues that support our educational and research programs. So, Ms. Sadro, anything you want to add to that?
No, I think you got it.
Okay, very good. So those were the three presentations today. Again, what we'd like to do today is take questions from you all. I know the Employee Advisory Council has had some questions submitted to it, so certainly we can start with those. But we certainly like to hear from you about what's on your mind. Were there points that we tried to make that were confusing in some way, that don't make sense, that need additional clarification? So if you have a question, please step up to the microphone. I'm going to move over here.
Okay. Well, I guess we'll get started with some of the questions that were submitted to the Employee Advisory Council, and we can kind of get the ball rolling and see if other folks want to stand up and ask some questions. We were submitted several questions for today's session via our website, and some of them covered the same subject matter. So in those cases, we just combined the duplicate questions into one. So what we've done is we've ended up with 9 questions that were submitted to the web. I'll start off and we'll see how it goes. So the first one is regarding compensation. It says, with mobile devices being eliminated and no merit increases in March, are you considering halting the at-risk bonus payments certain employees get?
I'll take that one. Is there anybody in the room who thinks they're overpaid? I didn't think so. You know, compensation is one of those things that always generates a lot of debate, particularly in large, diverse organizations where there are a lot of different types of jobs and a lot of different types of people. And of course, the strategic and tactical challenge for us is to make sure that what we're offering people is attractive so we can recruit new people into the organization, and it's attractive so we can retain great people in the organization. It rewards excellence and great performance as we go forward. Compensation systems aren't static. They change over the course of time. Market best practices change. And so we have to constantly assess where we are in that market, not only what the levels of compensation are, but the structural elements for compensation related to the different sorts of people that we employ. Now, there's some additional complexity for us because we're a state organization. So, for example, by law, we can't have incentive compensation systems for classified employees. So we have to work around that. We have to create a system that rewards great performance, that keeps us in the right place relative to all the different sorts of positions that we have here and the compensation associated with those positions. We also have administrative and professional employees, and we have executives. And the markets for those 3 major classes of employees all move separately. And the structure for market-based compensation is different for each. And so that's the context in which we operate. Every year we try to look at where we stand relative to total cash compensation. That's pretty easy to do with the classified staff, since salary pretty much is the basis for compensation for classified staff, again, by law. With our A&P folks, administrative and professional and executive, we have incentive-based programs, again, market-based, trying to do what other organizations like us are doing to incentivize people to reward great performance, to offer rewards for exceptional performance. So the question, this is a long-winded explanation, but I want you to understand where we stand with compensation. When we get into times of financial challenge, one of the first things that gets offered is, well, let's just start taking stuff away. Let's take away the support for the phones. Let's take away copiers. Let's take away different things, because that will allow us to reduce our cost. And in some cases, those are probably good ideas. And again, we look to what's happening, or look at what's happening in other organizations like ours for best practices. So that's one of the things that's occurring with phone subsidies right now. We found out we're the outlier in terms of paying phone subsidies. What most places are doing now is they're paying for the use of phones when phones are actually required for discrete job functions during the course of performing work. And that's the case for some of our classified employees here, but not true for most of the rest of us. So we've gone out and looked at the current market for phone-based subsidies, and we're trying to realign with what organizations like us are doing. And so, is that a takeaway for some people? Yeah, I'm giving up my phone subsidy. So, big deal for me. I use my phone as my private phone line. It's the one I'd have it anyway, whether or not I worked here. And so again, we have to be careful when we're considering what is a response to our current financial situation, what should we be doing with compensation systems and rewards based on what's happening in the market, and try to keep everything in the right place as we go forward. We're not trying to do takeaways. We're trying to adjust now, particularly in a time of financial challenge, to move some of our reward programs to be more market-based or similar to what's happening in other institutions. I think this question actually came from somebody who's mad because their phone subsidy is going away. And perhaps they don't have an incentive program. And so since something of theirs is being taken away, they think those bad old executives or A&P people should have something taken away too. Now, maybe not. Maybe I'm wrong about that. The good news for that person is the phone subsidies for all of those people they're mad at are going away because those are not market-based anymore. But with regard to the basic elements of our compensation systems, they remain the same. For people with incentive-based programs, the A&P and the executive folks, they will be negatively impacted by our financial performance this year. So if you're mad at those folks, then there's going to be a negative impact of our financial performance. That's the way those systems work. So kind of trying to put it all into one big picture, we want our compensation systems to be market-based, consistent with what places like us are doing out there. We adjust them as the markets change. We try to avoid takeaways. Now, if we're in a huge financial challenge and going into a hole in a hurry because like a big storm hits, then we're in a situation where takeaways probably are one of the few quick options that we have. But in general, we're trying to avoid those. So there will be a negative impact with folks who have an incentive basis to get them to total cash compensation, because an essential part of those systems is a good financial outcome for the institution. So we think we're okay. Do we need to continue to look at what's happening, what we're doing relative to what other people are doing? Absolutely. We try to do that on an ongoing basis. But I ask that you not confuse the responses that we're making to try to correct our financial situation with those things that are part and parcel of a market-based approach to compensation. Questions about that?
If I can change the trajectory just a little bit. One of the things I noticed earlier, you mentioned transforming healthcare. I'm wondering what we as an institution are doing with telemedicine and telehealth. Certainly I know we've had a strong presence in that in CMC services, but I'm wondering if we're doing other things that I'm not aware of.
Donna, you want to talk about that? Sure.
Sure. So You're right, telehealth has been something for which UTMB has been known, and in CMC, I think I have this correct, we've done over 100,000 visits this past year, so we are a significant provider of those services. So why aren't we immediately translating that to, to our own care within the organization? Well, there are a number of things that are actually going on that are pilots. I think one thing to remember, and is Becky here? No. I don't see, okay. And Becky will tell you this, I believe, is that, and certainly Cheryl can tell you this, we don't necessarily get paid for those visits. So that's something we have to negotiate into our contracts. We want to make sure when we do that, that we're prepared, we do it well, and we get paid. So a couple of things on the preparation front, knowing that we have, we have some work to do. One is that we're doing a pilot with UT Systems. So in Austin, people can elect to have a telemedicine visit. We're providing that, and we're seeing how we do that. And we want to do it so it's very smooth, very efficient, and making sure that it's efficient for the physician or the advanced practice provider and also for the patient. That pilot is helping us really better define those processes so that we are getting better at that. In addition, I know Todd, is Todd here? Mm-hmm. Where are you, Todd? There you are.
Reluctantly raised his hand.
Yeah, but IT has been doing a lot in terms of getting us ready to be able to do video visit capability. And I see Rex nodding his head as well. Would either one of you like to expand on timeline or how we, when we might do that? Maybe start with Todd, because he's the technical brain to make it happen, and then Rex from the physician point of view.
Yeah, so we actually are. We're working, as I think I mentioned a couple Mondays in March ago, on the technology. I think it's actually next week we start using, it's not exactly in a primary care visit, but our care managers are going to be using video visits as part of their follow-up practice, and I think that actually starts next week. Mm-hmm. So we are trying to insert the technology into sort of normal workflow in a number of places just to kind of get experience with it and to make sure that we integrate it into our, sort of normal operation. That easier, it's probably the harder side of that is on Rex's side as far as like how do we do that at scale given the financial challenges and sort of the context with which our providers practice. The other thing we've been talking about is I think in the eye and ear service line, we've been talking about doing follow-up visits. So some of you know, like if the patient's sort of in that global payment period for a service, we don't get paid for that follow-up directly. It's just part of the original payment. And so that's another place we intend to actually pilot the technology to make it more convenient for the patient, maybe even more convenient for the provider to do the follow-up. So again, a number of things happening. We think they'll all contribute to us sort of building this more robust service to the sort of non-correctional side of the house. And I think, and then like I said, I see a lot of things happening in that space. As far as general timeline, I think it's soon. I'd be hard pressed to put an exact time, but maybe Rex can comment from his perspective too. But I think it's definitely in the near future. It's not years away.
Well, Rex is getting the mic. One thing Todd said is the pilot with care management for post-discharge. That is really one of the areas where we can help patients the most, making sure after they're discharged, they're doing what they were told to do by their provider and following that. So sometimes you get a lot that hit you on that last day, whether you're the patient or you're the caregiver. And so these are intended to help follow up, make sure the patient's following what he or she needs to do, the caregivers or the patient understand what they need to do. And I put that in the context of I read something just this morning about a study that was done and how many patients, it was like, I want to say 73, but it was over 70% of patients who were discharged from the hospital don't really remember what they were supposed to be doing at discharge. It's just a lot to absorb that day. So these visits, although they aren't billable, may help avoid a readmission for which we wouldn't be paid. So it's work like that, and I think that's what we're trying to do is make sure we have the pieces right.
Thanks for leaving the timeline to me, Todd. I agree with all that Todd said. I think we will have this otolaryngology pilot that he mentioned up and going certainly by the end of this calendar year, hopefully by the end of this fiscal year. We're also working on a couple of other pilots that are probably too early to comment on specifically, but the other comment I will make is that I believe that that CMS plans to change Medicare such that in 2020, unless they change their mind, they're going to broaden the types of telemedicine and the scope of telemedicine for which they'll pay. Right now, they'll only pay in places that are underserved. My understanding is the proposal that's out for final comment would be that they would pay for telemedicine across the board.
And then the last place we're using telemedicine is internally from hospital to hospital. So for example, we wanted to be able to keep a higher level care for patients at the Angleton Hospital, but to do that we needed access to pulmonary services. So we're trying that through telemedicine as well. So we're seeing telemedicine having a lot of different applications, and I would say to the person who asked that I think that we're doing creating a good basis so that we would be ready to move when the reimbursement makes it favorable to do that.
Okay, and some practical questions. Some people have asked me, well, why don't we just hire Teladoc? Well, it's because they're really expensive. They've also asked, well, why don't we just dedicate some of our primary care physicians to answering the telephone for 2 or 3 hours a day? Well, then they're not satisfying that overwhelming demand we have for patient care visits. There's just a lot of practical aspects of this that we need to continue to work through. I know that other places are doing it, but typically those places own a health plan. And so they have a mechanism, if you will, for generating something to cover the cost of providing those telephonic services. So we're not in that situation, but we're pushing to go forward, defining what we think we should be doing through some pilots and some current engagements that you've heard described that we're rolling out or are out there in use. So we'll continue to push on that front. We just want to be in the right place at the right time and make sure that our costs are covered as we go forward. Other questions?
I'm coming from the context of a department that over the last 3.5 years has lost 9 research-oriented scientists who haven't been replaced. And formerly ranked as high as number 6 in NIH funding. And I understand that we have lots of limitations, but for the future, what are our priorities, strategies, topics, and timelines for strengthening our basic translational and clinical research?
I'll go first. I may not have heard all of that, Dr. Walker. Did you reference your department, your prior department first? You gave us some numbers there, right, as I think in terms of the concern. Yeah. Can't quite catch that. So if I don't catch it all, let me know. As I mentioned, and as Dr. Callender summarized, we've had growth, and I think we should be proud of the growth. Doesn't mean that we haven't had some things that I would rather have not have happened. Anybody that wants to leave, that we want to keep, and they still decide to leave, that's a problem. But on the other hand, many of those folks have gone on to other positions of leadership, which I think is part and parcel of what we do in academic medicine anyway. So what do we do next? I think it's about, I have to go back to this idea of margin. In every moment when we think about our future, it's how do we generate margin? And part of that discussion says when we generate that margin, we will invest in all of our mission areas, not just patient care, but also research and education, even administration. I think the key then for FY18 and 19, and I don't want to get too particular about your department, but the key for FY18 and 19 is going to be the budgetary challenges that we're talking about. There are already dollars that have been invested. We'll continue to do that. As you probably know, we subsidize a significant amount of research at this institution. For example, I think that 20% change, say $7 million in increased support, means that the institution pays 45, 35 cents on the dollar just to support that infrastructure. So although we're successful as regards our research enterprise, there's investment that must happen concurrently. What is the way to actually speed that up? Well, I think we've done a really good job in terms of recruiting, but there's always an opportunity to do more. I think Dr. Laposada, taking over from your fine department, is very much tuned in to trying to make sure that it continues to grow and prosper and goes back to those lofty heights. Actually, in terms of number of grants and number of fundings and amount of funding and number of grants in pathology is actually up, although we've lost some people. And as you may know, pathology is one of the departments where the president has authorized us to invest some additional dollars just to go forward in trying to strengthen the basic science component in that department. That set aside for this year was $400,000, which is not a small amount given the challenges we've been talking about as regards our budget. What we do in 19, well, I think will center around doing these other things that are important for our mission areas. So last comment I'll make, and Ms. Clarity is in the audience, I think academic institutions are all facing this. How do you make sure and grow and maintain your basic science infrastructure, your basic science programs, your translational research, your clinical research, in the midst of all these things that are happening, where at the bare minimum there is uncertainty about the future of reimbursement. To me, that says that philanthropy and development becomes even more important. And I think we've done a great job there. So how do we actually identify additional dollars to recruit the best and brightest, to retain the best and brightest, besides these efficiency, effectiveness things I'm talking about, as well as maintaining the joy that's part of being in medicine? It's going to require lots of help from Ms. Clarity and Dr. Callender. My line, which is hopefully gaining traction, the end game is a fund for every faculty member, a scholarship for every student. In order for us to succeed, we're going to have that kind of laser focus going forward. Doesn't mean I don't worry. Spend a lot of time, what's the old line? Once a day, every day, all day long, worrying about what you're talking about, Dr. Walker. But what I'd like to conclude with is, rest assured, we look at it as a leadership team on a regular basis. We have the support of all the people sitting here. It's just very difficult, but not impossible. I think we'll get it done. Yeah.
Priorities and topics, not only in pathology and not only basic science, but also translational and clinical. I didn't mean to focus on just pathology.
So as has been announced, and as Dr. Callender has said, we want to focus on infrastructure. In terms of the spaces we can occupy, where I think we can actually do an even better job in the short term, it's going to be on clinical research. That in no small part led to Dr. Urban's appointment as the clinical research officer for the institution, one of the very first. The research strategic plan outlined in my talk, it's identified a number of areas that are all important in terms of where we can have synergy. It talks about infection and immunity as being foundational, and it also talks about the neurosciences. So I tried to give you a little snapshot of my presentation about that investment, but that investment has been strong, including some of the equipment piece, but also in terms of the people. So I think those are still going to be the keys for 18 and 19, but I really want to say that the infrastructure piece becomes critically important. Like every good strategic plan, we have to ask, do we have the right people, I said this in my talk, in the right places, doing the right things, the right time, for the right reason? I think we do. Can we speed it up? I wish we could. Will we speed it up as our means provide the opportunity? Absolutely. Is that a better answer, Dr. Walker? Thanks.
Thank you. Other questions?
This is another question submitted in the EAC and about coming back to compensation again. This is from someone who works in the health system who is concerned about the delay in merit increases this year. Over the past couple of years, the university has made changes to my compensation that have resulted in significant changes in income. For instance, the change in FTE status created a considerable decrease in yearly household finances. The last market adjustment occurred in 11/2016. Now, what is the hospital doing to ensure that home employees are on par with other competitors in terms of compensation?
Start with that one.
I'll start with that since it says health system in there. And, it's a great question. And I was fortunate because we were given some idea of what the topics might be. And this one is certainly of interest, I think, to all of us up here, but certainly to me. And I am going to call my good friend David Marshall in a minute to fill in what the details I will have forgotten, I'm certain. But there have been changes, particularly in nursing when you think about the schedule. We went from a schedule that had 5 8-hour days for nursing to a schedule that has 3 12-hour shifts for nursing. And so they went from 8-hour a day to 12-hour days. And that was to be consistent with the market. If you go up into the Texas Medical Center or in some of the Clear Lake hospitals, you're going to see that's a very common schedule for nurses. And we tried to modify what we knew would be an impact by giving a long lead time to talk about that, to hear questions, to be able to answer them, and to give nurses time to prepare for that shift. So that was a market-based shift, much like Dr. Callender talked about. Now, compensation is extremely important. We partner with HR, who does compensation assessments for us by different job category. And so we are going to be soon looking at the most recent data. When we saw the data earlier, probably we saw it about not quite a year ago, but when we saw it then, we made adjustments that the market showed were appropriate, but in this case, we had just made some large adjustments in nursing, and the data was showing that we were competitive. I suspect, as your questioner probably assumes, that we're going to see some differences this time when we get that data to review. We are committed to market wages. We are committed to market schedules. We are committed to having a great environment for patients to work in. It's not only nursing. People say to me, am I only worried about nursing? Of course not. I'm worried about making sure we have market compensation for all of our jobs so that we can be able to attract the best and the brightest. Sometimes some of the jobs don't move according to the market data and may not move for several years, and that's the market. And I know some people get disappointed when they don't see wholesale shifts in the range of compensation that they're in. David, do you want to speak a little bit to the market survey for us, more specifically than I did? Thank you.
You did a really good job. I'm not sure how much I can add. I will say that we had been eyeing the move to a 36-hour work week for nurses for a number of years. We had to get legislative approval to offer full-time benefits for a 36-hour work week. We got that approval for nurses. We put a proposal together which required the president to approve to be able to do that. We gave our nurses about a year's notice that we planned that change because we knew that it would impact them because they wouldn't be working 48 hours one week and 36 hours the next week. That's the way they had worked. Nursing fatigue is shown to play a huge role in patient safety, so we thought that the fatigue of nurses was something that we should pay attention to. In the market, almost every hospital in the market has 36-hour work weeks for nurses, and that's why we decided to make that move. As Donna said, we partner with our HR compensation colleagues. They look for one survey that comes out almost at the beginning of each fiscal year, the August-September timeframe, and that's when we make the decision when we're going to do compensation adjustments based on the market. As Donna said, the past August-September timeframe, the data did not show that we needed to make another move after we had made the one in 2016. We do anticipate, as Donna said, that the market may have shifted and that we'll have to do something when we get the data in August-September 2018.
And then Deb, I don't know if you have anything to add for the rest of the employees. I mean, we really do look at that data every year.
That same thing goes for all the bands of employees that work in the health system. We look at every job category across ambulatory, hospital, every work site to make sure that we're compensating according to the market. It happens for the CMC employees, And sometimes the legislature handles them a little differently than they handle employees in the non-correctional health system part of the world. But that all gets looked at least once a year, and sometimes we look at different categories a second time each year.
And we are committed to merit increases in the fall, so those are being built into the budget. I'm the one who made the decision to postpone the merit increases this year. That was driven in part by our financial situation. We're looking for opportunities to save some money right now because of the impact of Ike and some of the other things that have hit our bottom line this year. More importantly, we've been out of sync with regard to our evaluation process, performance management, and then the rewarding of people with merit increases and market adjustments and other compensation changes for about 3 to 4 years. And so we're saving some money for this year by postponing those merit increases from March until November. That allows us to align our performance management system so our managers and supervisors can do an end-of-the-year evaluation of performance, and then that can be considered as we make those compensation adjustments for the coming fiscal year. So it's a combination of financial challenge and the need to fundamentally align the reward system with the evaluation or performance management system. So that's the reason for the change for this year. And we will have new market data. We'll be able to look at where we stand, and we expect to be in the right place relative to the market. We know we can't attract people and we can't retain them here if we're not in the right place relative to the compensation markets for all the different sorts of positions that we employ. Patrick, you have a question?
Yes, thank you. I appreciate very much your leadership and comments made today. One question I have to you all is that as we see the need for rapid change within the organization, and I think everyone embraces that very much, one of the pitfalls of any large organization is the ability to implement that change in a pretty rapid fashion necessary to meet what we have to achieve. And my question is just very general. It's very broad-based. I apologize for the extent of it. But as we as an organization grow and develop, we have, how do we improve the forward flow of action within our institution through our committees, the functionality, that forward momentum to implement the changes necessary to meet what we have to achieve? It seems that we have many very, very good committees, and probably some that have been around that at this point now are not as required as they were previously. And how do we move our resources around to focus on the things we really have to, rather than getting caught up with some of the previous things that weren't quite so important? You see, so the shift of forward momentum into implementing the changes necessary.
Yeah, thank you for that question. To me, that's a part of transformation. If you lock yourself into doing the same things you've always done, you'll never be able to transform to be what you need to be. And we continue to think about that. It's always a challenge in large organizations, but eliminating portions of the organization, elements within the organization, structures, committees, whatever that really don't serve high priority. They may still perform good work, but they may not be doing what we need those resources, the cost of those resources to be contributing are resulting in a return, generating a return. So we're always looking, Patrick, and I think you've seen us now come up with innovation forums that Dr. Sharma is leading to bring in people who are talking about how big and small organizations innovate, how they get engaged in transformation. But I was, along those lines, I was talking with one of our really wonderful basic science chairs this morning. And we were having a conversation, and I said, well, what we really need for you to do You as a leader among the basic science chairs is to help us with those things. We have a lot of really talented people in the organization who understand where we need to be. We need more feedback, more suggestions about let's do this, not this, as we go forward so that we can manage that transformation process and, if you will, speed up as you're suggesting, so we're in the right places at the right time. I guess bottom line is we all need to continue to keep our sleeves rolled up, look at what we think are our highest priorities, and think about how we change existing processes to become more effective and efficient over the course of time. Other questions?
Hi, this question was also sent in to the EAC and regards compensation. Please give an update regarding an incentive plan for nurse practitioners and physician's assistants at UTMB.
Dr. Jacobs? Yeah.
Yes, thanks as always for the question. So the update is as follows. As you may have noticed in my Mondays in March, if you had a chance to see it, we talked about a couple of things. One, what we could do in the interim while we revise or revisit the current faculty compensation and incentive plan. I think there are a couple of keys. Although there are many of us who spend a lot of time asking ourselves what is the best faculty compensation or provider compensation plan in the new millennium, it is another moving target. So we thought it would be important, with Dr. Callender's approval, to bring in an outside consultant to actually look at our plans. And one of the things we're going to ask them to address is, what about advanced practice providers? Equally importantly would be, what can we do to make sure we recognize the efforts that we engage in as a team? So, we have a pretty strong individual component to our current faculty compensation plan. It has a group component. It has a value, quality, outcome component. But the question is, do we have that right? And given that the future of healthcare, I think, will increasingly move towards team-based efforts, patient-centered team-based care, is it time to make a modification of our plan? Here's what I think will result. At the bare minimum, with the President's approval and with my colleagues' input, you can expect that the faculty compensation plan implemented in FY19, although we may have to issue shortened MOAs 6 months through the year, will have, of the dollars available for the group component, set aside to recognize the members of the team in terms of their contributions. So that's a place, at least in the academic enterprise, for folks who are not physician faculty or DO faculty or the like, can actually also have some recognition towards their contributions to the team. The other piece that has to happen in the short term is Ms. Sollenberger and I also, I think, will want to talk, because I think this issue of compensation for advanced practice providers extends beyond the academic enterprise also to the health system at large.
If we're talking about compensation, we have to talk about parking.
No, thanks.
Those two are always, at least when I talk with employees, those two are always at the top of the list. So one of the things I saw, and I've been, as usual, talking to different people and groups around the organization, there's a disparity in the way that we manage parking, because we charge for parking on the main campus. We don't in the League City and Angleton areas, and then our clinics, most of them are in lease space, so usually it doesn't cost anything to park. So particularly with more employees moving around now, how do we reconcile all that and come up with a cogent approach to managing parking cost, people moving around as we go forward? I know you have the perfect answer.
I do.
Good.
I'm done. Did y'all get that? It was the perfect answer. Thank you. Mike and team right now are right in the middle of finalizing a transit and parking plan. It is true that we don't charge for parking at some of our sites, and mostly that's driven by the competition and what we see other healthcare institutions doing. So we don't want to place a barrier in terms of being able to attract qualified people in certain areas by having that as a non-competitive issue. What we are going to do is make sure that as we do charge parking, and we do that, remember, to maintain some facilities that we have. So we have parking garages, and we do have to keep those parking garages up, provide security, so on and so forth. So we do need to have that income to do that. What we're going to do, though, is make sure that if you are a UTMB employee and you pay once. So Mike's trying to figure that out, and I'm sure he's got a brilliant answer he'll bring to us in a couple months. But he's trying to figure out how we manage that process. So if you pay for parking on the Galveston campus and you go to League City, you shouldn't have to pay again to park there. So hold on, there's a plan coming. We'll roll it out in the next few months. But we are looking at those issues. We know they exist. We do have to address what's competitive in other marketplaces as well.
Yeah, thinking about what happens as we, please, as we go forward, what happens maybe in 4 to 5 years when we have a lot of driverless cars on the road? People don't really need to park. In fact, if you look at the parking garage that we're building in League City, its floor to ceiling heights for the first 3 floors are designed to accommodate build out of a building. Because we may not need parking in the future. So, we just continue to think about, okay, what is the parking issue for the next year, 3 years, 5 years, and beyond? Because it's probably going to change markedly as the modes of transportation change. So, a lot to consider.
Just on article on driverless 18-wheelers. Now, if you think cars are scary, can you imagine?
I won't be riding my bicycle on the feeder road, that's for sure.
No.
Yes, sir.
Yeah. My question has to do with faculty, number of faculty, and replacement of faculty positions. It is the perception that compared to prior years, the number of faculty is decreasing. What are we doing to ensure that the workload is aligned with the number of faculty?
Dr. Jacobs, did you hear him?
Yes, I think I did.
Okay.
Yes. Can you hear me okay? If I don't get it right, let me know. So actually, this idea of workload is critically important. The challenge for us is, given that we are all being asked to do more with less, how can we be more efficient and effective? So that's part one. And how do we maximize our productivity? There are many examples of things we're trying to do, academic enterprise and in partnership in the health system. The SCRIBE program is an example. How do we take some of that burden off where it's relevant? The other thing we're talking about is how to help the whole team practice at the top of their licenses so that that workload gets distributed. I think there's opportunity, too, in terms of thinking about the administrative paperwork, where with Mr. Leach and others, we're asking ourselves, how can we make our IT tools more effective? But I think the other thing that's important to answer as part of your question is, there's no set number. And actually, if you look at the total number of faculty members, it's actually gone up in the last 3 or 4 years. So the number is not decreasing. Actually, the number of faculty members has gone up. Now, the real meat in your question is that still may not be enough. So I think we're going to have to work smarter and probably work a little harder. But I think we're all tuned into that and ask ourselves every day, what can we do to make it a little bit easier, make it a little bit more effective, make it a little bit more efficient? And if people have that joy, where I started from, if you have that love, we help you recapture that love, then you're working hard and enjoying your work. That's my thing.
Thank you.
Thank you, Tony. Okay, one last question. Anybody have one?
So this question is regarding quality rankings. The Vizient ranking is nice, but this is not a study that even Google can find. Can our focus shift to a more external-facing ranking like U.S. News, which is a starting point for many of our patients when researching where they might consider treatment? Our current overall ranking is 33 in Texas and number 9 in Houston.
That's a great question. So the Vizient survey, for those of us in the know, like all of you here, is important because it ranks us relative to other academic health centers in the country. So that's why we were we worked on that so hard. It also covers, in its 6 areas that it focuses on, it covers so much of what we need to be good in, from patient satisfaction to mortality to patient safety, has complications, areas where we're looking at length of stay and so forth. We have done well, and it was a great way to learn how to work better. There is more to do. it was interesting, within a couple of months after we received the news that we were number 9 in the Vizient study, Dr. Sharma came to me and he said, okay, now that we're doing that pretty well and we're going to keep up with that, I want to focus on how do we get and maintain a better score in Leapfrog. That is one that you can find when you do the internet search, and they give the hospital name, in like type font of 10, and then type font of 24, the grade, the letter grade. And so we had not been doing as well, but last year we got an A, so we were pretty pleased. That's one way consumers can find us. Other ways that they can find us and that are much more publicized are the U.S. News and World Report, which is the one I think that you referenced. And Dr. Sharma has talked with all of the clinical leaders about what we need to do in order to improve our ranking in that area, because some of the things they measure are ones that we are interested in, but they also measure things like access to the latest technology, your number of nurses to patient ratio. So the lower, the better, the more opportunity you have to get a higher score for that. But it's also reputational. So when physicians will get a survey, he talked about the importance of completing that survey and of making sure that we were more top of the mind awareness. So there is work that's going on to try to improve our ranking in some of the more publicly available surveys. So if someone does do that Google search, they're going to see UTMB in a more favorable light. So Leapfrog will help. We've got work to do in U.S. News, but we're working on the technical things we can work on, but the reputation, getting the good word out about the work that we do here is absolutely essential. And so that means the experience that our patients have should be a great experience. Just like we said, we want them to have the right care at the right time, every patient, every time. And we have to continue to emphasize that so that as people talk, UTMB comes up as really a great place to receive care. It does us no good to kind of hide this little light under a bushel and go, oh, it's really nice, nobody knows about it but us. We need to get that word out more, and we can do it by giving our patients a great experience because they go tell other people that as well.
The strategy really is a lot like a lot of the other things we've done, where we focus on an area, an opportunity to make a big difference, to gain recognition from making a difference or making an improvement, and then let that grow over the course of time. So because the U.S. News ratings are so heavily driven by reputational score, we really have to be doing well with Leapfrog, with Vizient, with a lot of the other measures before we can ever be in a situation where that reputational score can move us up significantly in the U.S. News rankings.
There's some organizations that they study to the test. In other words, they have a full-time person. I won't say who in the Houston market does this, but they have a full-time person assigned to literally making sure that they perform well in those metrics so that they will get a high score in U.S. News and World Report. We haven't done that kind of investment, and we've still made progress because people, the physicians, the staff, are educated and they know more and more what to do. So I think that we can do it in a much more effective manner, and that's cost effective as well.
Yeah.
I think, I appreciate the discussion as always, but I think Vizient is an up and coming metric. I think, stick around a little bit, I think you'll see it kind of creep up on the Google pages. When I travel around, folks talk about it a lot, because I think there are some strengths to that index. Not that the other indices are not strong, and not that U.S. News and World Report isn't important, but there are some particular strengths of the Vizient survey that I think people are noticing.
It's certainly better aligned with reimbursement systems.
It's also one that's a proven survey. The methodologies are much more proven than any of the other surveys. So again, I think that's one of the reasons we want to perform well in that, because it can translate into other performance that's good, but it's more, it's a more scientific study.
Yeah, validated. Okay, one last thing from me. As I've been talking with different groups around the university over the past 6 to 8 weeks, the question that people are asking me are, if I ask them about, they acknowledge their concern about it, am I going to have a job? The concern is that the 4 of us and our executive leaders aren't telling the whole story. We're hiding something, and the other shoe is going to drop. And so that's very understandable. If you look back at the history of this institution, going back into the 80s and 90s, there were a lot of significant financial challenges, and there were a lot of layoffs across the board, reductions in force, which were necessary because there needed to be a quick correction in financial outcomes. I think I've mentioned before that the 4 of us are not big believers in that approach. Is it necessary on occasion? Yes. For example, after Hurricane Ike, we did a big layoff because we had no money coming in with our hospital closed for over 5 months. In this situation, though, I mean, we've seen significant losses. What we believe we see is that our expense structure here is not where it needs to be. We're getting further and further away from national benchmarks relative to best practice for expense management. Now, had Harvey not come along, not had its impact, maybe we could have gotten by for another year or so, but that's not the case. So that's the reason we're all now looking and talking with all of you. What are we paying for in terms of expenses? These different service contracts we have, how we use our computer systems, our telephone systems, how we deploy people, how many centers do we have in the academic enterprise, trying to take a look at how we increase our efficiency. If you look at our overall expenses, and you all see this every month in the pie charts and the information that's put out by finance and distributed to the academic enterprise and the health system, about 60 to 70% of our overall expense structure is related to how we use people. And another 20 to 25 is related to supplies and pharmaceuticals. And so those are the 2 big expense categories we continue to look at. We're not planning on an across-the-board layoff. Okay, now, if somebody from Austin calls and said, we've had enough, you have to do that, we would do it under that circumstance. But right now, that's not happening. What we need to do, though, as we go forward, is look at how we're using our people, look at how we're using supplies. Look the other day at, for example, how we're using the different prosthetic materials we use in orthopedic surgery. We've been through a significant exercise in the past to try to limit our use to 2 major types, with an opportunity for a surgeon in a special circumstance to seek to use another type of prosthetic. It turns out that over 50% of the time we're going off contract, and that's driving up our costs. Is that really necessary? Probably not, but we need to discuss that with the orthopedic surgeons and see if we can move back to where we think we need to be. Those targets, those expense targets, where we think we need to be, are again driven by national benchmarks that come from organizations like UTMB. If you're following the trade journals, you've seen a number of organizations have been through the big layoff. They've been through the big reorganizations. They're changing the way that they manage their expenses. We want to do the same thing. We'd like to avoid the layoff approach. But to do that, we need for everybody to engage now, to take a look at how we're doing things, what we're doing, and come up with more effective and efficient ways to do our mission work and the work that supports it. So we'll be talking more about that over the coming weeks. looking at ways we can use our people more effectively, use them better as we go forward. So will we eliminate some jobs in the process? Yeah, we've already eliminated some vacant positions. Will we move some people around within the organization? Yes, reorganizations will be necessary so we can get our expense structure in the right place. That said, nobody who's sitting up here wants to see anybody lose their job. So as we go forward, we know we have great people who are committed to our organization. We'll be looking for opportunities so that everybody who works here now can still contribute in some way. We may just have to ask some people to do different things than they've done in the past. Certainly with regard to use of our resources, with regard to our programs, we need to go at some of them in a significantly different way. And so we'll be talking more about that. In some cases, we'll be dictating change, at least to move us along towards getting where we need to be. We understand that change is an iterative process. We always need to look at changes and their results and then try to adjust to get the best outcomes we can. But we're in a situation now where we need to do things differently, and we're going to drive forward to make that happen over the coming weeks and months. So I just want you to understand that we're not planning on across-the-board layoffs. You won't see that 7% has to go. But we will be looking at how we use people. We'll be asking some people to do things quite differently. We'll be eliminating vacant positions, in some cases eliminating filled positions and moving people around so we can get our people expense structure in the right place. And we'll be looking at how we use the resources that are required to do our work and planning to do that differently as we go forward. So we put ourselves back in a position of being aligned with best practices across the country. So hopefully that at least you understand now what we're thinking. You understand we don't have anything hidden. This requires engagement from everybody to get this right as we go forward, so we can avoid being in that situation where we have to make more difficult moves. You guys want anything to that?
No, I think you said it very well.
Okay, so that's where we are. So let's roll up our sleeves and get at it. Thank you all very much.
UTMB Health, working together to work wonders.